Okay, so it's just 2 minutes past the hour, so I'll just get started. Thanks to everybody who's coming. People will still be coming in the next few minutes, so I'll just get going. So this is an important webinar, so thanks to Dr. Elizabeth Rapa and Dr. Louise Dalton of the Department of Psychiatry at the University of Oxford for this. So the topic of this webinar is communication with children about life-threatening conditions and implications for long-term psychological health. I think that by now we're all quite familiar with the many ways this pandemic is changing how we live, and the many implications for our health aren't fully understood yet. The first casualties of this pandemic have been residents in long-term care facilities, such as nursing homes. And as we move through the year, we are seeing different demographics being affected in different ways. That's one of the reasons this virus is being taken so seriously by almost all countries. One of the other side effects of the pandemic is how it could be affecting the mental health of healthcare workers and those living in isolation. So thankfully, these areas of concern are becoming more widely discussed. But today's topic is one that involves our children. We all agree that children must be kept safe, both physically and psychologically. So understanding how to communicate in a way that doesn't add to the trauma of losing a loved one, I think it's vitally important for anyone who works with children, even seldomly, to know about this. So I'm very grateful to both Elizabeth and Louise for generously offering to speak to us today for this webinar. Both Elizabeth and Louise are part of the Child and Adolescent Psychiatry Group at the University of Oxford, which is under the leadership of Professor Alan Stein. The group focuses on decoding the key mechanisms underpinning child development, including the intergenerational transmission of difficulties in the context of adversity. And one of the team's main areas of research focuses on the way children are told about the diagnosis of their own or a parent's life-threatening condition. In response to the current pandemic, the team have developed a platform of resources to support healthcare workers and caregivers with the unenviable task of telling relatives and children of an adult's death. So again, I'd like to say thank you very much to Louise and Elizabeth, and we will have an opportunity at the end to answer questions. So if you look at the bottom of your screen to any of the attendees here, there is a Q&A box button. So if you type any of your questions into that, that you might have throughout the presentation, and we'll get to them at the end. So hopefully we'll be finished in the next hour, and we'll have maybe 10-15 minutes at the end to go through any questions that you have. So thank you very much and enjoy the presentation.
Thank you so much. I'm going to turn my video off now just to stop any problems with bandwidth, but I'll put it on again at the end.
Sure.
So thank you so much for giving us this opportunity, and thank you for that great introduction. I probably don't need to talk very much about my first slide because you so beautifully just described who we are. But yeah, Louise and I work in Alan Stein's group. Alan Stein's group on lots of different things, very much focused on children and adversity. But one of our main projects at the moment is about how we communicate with children about life-threatening conditions. So as you so nicely told everyone, we are based at the University of Oxford. And so today we're going to talk, an overview of the talk is that we're going to talk a little bit about why, how our studies have come about, what evidence we have about the importance of communication about illness and death, some of the resources we produced in 2019, which was a framework, and then much more recently, specifically about COVID. So if we kind of first think about how communication with children has changed over the last 70 years, in the 1960s, it was universally thought that children shouldn't really be told anything about their prognosis or their diagnosis. But then over the next few decades, there was just this increasing recognition that actually telling or disclosing, which is a word Louise and I will use quite a lot today, which I'm sure all of you know what that means, but it means telling. So disclosing to children about their illness, and this was in part really due to advances in care and treatment, so therefore survival rates go up, and also that we appreciate much more about children's evolving understanding of illness and death. We now much more recently tend to acknowledge that the whole family is affected when someone is ill, and so we adopt a more family-centered model, which is often used in paediatric care. There's also that change in the relationship between doctors and patients, and this is around shared decision making and empowering patients and children to advocate for their own care. So why is communication so important? Well, if we think about when a child is diagnosed with an illness, it completely provides them with an explanation of why they don't feel so well, or why they're going to the doctors, or why they're having procedures done. So therefore, if they have this basal understanding that they're not very well, and even depending on their age, the name or prognosis of the disease, it means that, of course, they're going to cooperate more with going to doctor's appointments and allowing people to take blood or actually have operations. And then that in turn helps them to adhere to treatment regimes, which, of course, all of those things combined actually can affect the course of an illness. And if the child knows what's going on, especially maybe when children are slightly older, it means they can advocate for their own care and say what they do and don't want to happen. If we then think about when a parent is diagnosed with an illness, of course, if we don't tell children why we don't feel well, or changes in maybe your behaviour or even in your appearance, children are going to notice all of these things. They're going to know that people are having phone calls, or I know things have changed a lot now during the pandemic, but they're going to know that mum maybe is more upset, or dad is more irritable, or that they're going to a different place more often. So if you don't tell children why all these things are happening, they're going to try and make sense of this completely on their own, relying on these observations, and they often construct their own reality that more than likely is not accurate or true. And then this could leave a child feeling guilty because maybe it's something they've done why mummy and daddy aren't around so much. They feel isolated because no one's telling them anything different, so they're left there with their own feelings and actually become quite fearful of what's happening to them. So as you can imagine, all of these things combined when a parent's diagnosed with an illness or a child, that it is going to affect the family and the children psychologically and physically. And very much in line with ISQua's mission of improving healthcare, we know that if all of this communication is done much more effectively, it could actually improve the quality of the healthcare people are experiencing. One of our colleagues, Sophie Ratcliffe, writes very powerfully about what can happen if children are not told about an illness that's happening within their family. And she does this in her book called The Lost Properties of Love. So here you can see, if you read this quote, she is describing her experience of having to sleep on the landing outside her parents' bedroom, even though she obviously had her own bedroom, but she thought she needed to do that to protect her family from burglars. Whereas in fact, this threat of burglars was not a threat of someone invading their house, but actually that everyone was keeping the secret from her that her father had cancer.
So if we think now about perhaps a developmental context for talking to children about life-threatening conditions, it's important to acknowledge that there are several very well-established models for breaking bad news, but these are very much adult-focused, and they don't take into account that children's understanding of what illness and death means changes as they grow up. And for chronic illness, of course, these conversations about an illness within the family are not one-off events, but they need to be repeated and elaborated upon as children's understanding develops over time, so that communication and information that they're given reflects their changing and evolving understanding. So just a very brief recap of some of the developmental context for children's understanding of death. So what's considered a mature understanding of death involves acquisition of a number of concepts. These are that once something has died, it can't be made alive again, that all living things die, including ourselves, an understanding of what happens physically after death, and also what might realistically cause something or somebody to die. Although very young children do not understand illness or death per se, even infants are very attuned to subtle changes in the responsiveness of their parents or their caregivers. So under twos will notice the absence of a parent or familiar person who they're used to looking after them. By 3 to 4 years of age, children understand that living things die, but not necessarily that death is irreversible. So it's important to repeat to children that the dead person cannot and will not return. I particularly wanted to draw your attention to magical thinking, which is a common stage in children between the ages of about 4 and 7 years old. In this audio clip, Maya Angelou powerfully describes her own magical thinking after a serious sexual assault in childhood. The clip is exactly 1 minute if anyone would prefer to mute for its duration and then rejoin us afterwards.
When I was 7.5, I was raped by my mother's boyfriend. And the rapist was killed. The policeman told my grandmother, my mother's mother, with whom I was staying, that the man had been kicked to death, they thought. And I heard that. And somehow, with my 7.5-year-old logic, I decided that my voice had killed him. That because I told who did it, that my voice was the culprit. And so I decided that I'd better not talk, because anybody whose name I called or who heard me might die.
So magical thinking means that we need to be really careful with the language that we use. We need to be very concrete to avoid confusion. In the UK, we often use euphemisms to talk about death, perhaps in an attempt to soften the harsh reality of what that means. But actually, these euphemisms can create misunderstandings. For example, if we say that Grandad has been lost, a child might think, well, maybe if we only search hard enough, perhaps we can find him again. So if we think now about adolescents, adolescents have a sophisticated understanding of death, but changes into the brain during adolescence means that they have a much greater focus on short-term consequences, which can affect their decisions about their own treatment. For example, I can't possibly start treatment because I really have to go to the party at the weekend. But some of the, again, I guess if we think about some of the normal tasks of adolescence, so separating from their family, achieving independence and autonomy, these can be significantly disrupted by serious illness within the family, when adolescents may find that they're pulled back into their family unit, either due to their own ill health and their care needs, or because they need to take on caring responsibilities when a parent's unwell. Some of these challenges specifically for adolescents have been recognised in the development of services for this age group, known as teenage young adult services in the UK, which are particularly prevalent for young cancer patients.
So thinking about what our project more specifically, in 2019, our group was invited by the Lancet to write a series on how to communicate with children if they have a diagnosis of a life-threatening condition, or if their parents receive a diagnosis. So as you know, our group is led by Professor Alan Stein, and so we were asked, because of the work that he's been doing over the last 30 years, researching into this area. And that has been from his first work, where he talked to mothers who have been diagnosed with breast cancer and discussed with them how they did or did not tell their child that they were suffering from breast cancer. And then more recently, our work on an intervention study which supported HIV positive mothers in South Africa disclose to their children their HIV status. So what was clear from all of the work we've been doing is that there was a lack of specific guidelines about this point at diagnosis, and also specific training for healthcare professionals on how to do this. which is quite surprising, really, considering that we know that life-threatening conditions are diagnosed millions of times a day. And when we think about life-threatening conditions, our description, or our definition of that, encompasses lots of different diseases, not just the obvious ones like cancer and HIV, but any disease that's diagnosed where potentially can have an impact on your family and not always ultimately leading to death. And what we do know is that when you are diagnosed, or your child is diagnosed with a condition, this moment is remembered vividly and often predicts how you are going to feel or interact for the rest of the course of the illness. So as part of our Lancet series, we also had a workshop which included experts from both lower middle income countries and high income countries from a range of different experiences and range of different job roles. So, like I said, we had 2 papers and also an editorial looking at all of the evidence in low middle income countries and high income countries on what has been done so far in looking at how children are communicated to about illness. So I'm just going to go through some overall findings, and then we'll go into a little bit more specifics about each different paper. So what I can tell you is that the research is absolutely disproportionately focused on cancer in high income countries and HIV in LAMICs. And also that we know that this is rarely a primary research question, communication, but forms part of other studies. We found that the disclosure rates varied hugely. So for child illness, for example, if we think about HIV, between 1 and 40%. So although people acknowledged how important it was to tell children, as shown here in this study, with nearly 80% of parents saying, yes, we should tell the child, actually only 90% did. So that was really interesting for us. And similarly with parental illness, children were often not officially told, but still knew what was happening with their parent. Highlighted perfectly here in this Chinese study. So although less than 40% of the children were told that their parent was HIV positive, 80% of those who weren't told knew anyway, or were aware something was really wrong with their parent. So from our reviews, what overall we found is that children want honest discussions about the diagnosis, prognosis and illness, and all these studies consistently reported this. So if we now think about child illness first, we know this is very common, shown here by the stats for cancer and HIV. And like I said a minute ago, we really want to make you realise that this is relevant to a wide range of specialties, not just HIV and cancer, but cardiac, renal, infectious diseases, etc. And as I've said before, we do a lot of work in lower middle income countries. So it was really important that lower middle income countries had an equal amount of evidence presented in these papers, especially when we can see here how the survival rates differ so hugely and are so much poorer in lower middle income countries. So what did all the studies that we reviewed showed in terms of actual outcomes? So generally we saw benefits in relation to emotional and behavioural and social outcomes. So by telling children about their illness, results found reports of lower psychological problems here in cancer and HIV, with actually anxiety and depression being lower in children who were told about their illness. And actually, if you didn't tell children about their illness, you saw an increase in reported problems, shown here as emotional difficulties. we know that communication actually helps children understand more about what's happening to them and what's going on. And therefore they showed increases in trust that they had with their parents and actually healthcare professionals. And like I said before, that means that they will engage better with procedures and treatments. And therefore, again, very much in line with your mission, that the great work you're doing here, is that that actually leads to better healthcare, because the children are engaging more and actually their treatment is working, and hopefully their illness will be better. So we also know that an awareness, so a child's awareness of their illness also impacts on their behaviour. So we can see here that, especially associated with HIV, if a child knows that they're HIV positive, they actually have a better understanding of their diagnosis, and so then change the way they interact with their peers and other, the wider family network. So we see here that they practice safer sex when they know that they're HIV positive, whereas in fact, and that they were more likely to tell their sexual partners and practice safe sex procedures. We know that communication can even affect the progression of a disease. So highlighted perfectly here by children that did know they had HIV actually had improved CD4 counts, whereas non-disclosure, they actually had lower CD4 counts, so actually physically affecting the progression of the disease. We know that effective communication also has a relationship with outcomes of parents and caregivers, and actually the whole family. So when children were told they had an illness, they actually felt more supported by the parents and healthcare professionals. And in fact, parents reported that it was a relief to finally tell their child that they were unwell, and this was no longer a secret that was kept within the family. We actually know that caregivers felt that it was a good thing to do this, as shown here with a Swedish study. Over a third did tell their child that they were going to die, and none of them regretted it. And actually, of the 66% who didn't, a third of those nearly did regret not talking, and actually reported increased anxiety and depression as a result of not talking to their child about their death. It also helps with the parent satisfaction with healthcare professionals. So this study in Egypt showed that there was a relationship between parents' satisfaction with the healthcare professionals' communication style that actually led to more trust in their child's physician. And this was shown to also lead to a more positive view of the future for the family.
So if we think now about communication and how and where it happens, of course it isn't linear between one individual and another, because when a child's unwell, we can think of three key stakeholders: the child, their parents, and the healthcare professional in a dynamic triad. Of course, when multiple medical teams are involved in a child's care, or parents are separated, this becomes even more complex. So if we start with the children, and in terms of what affects their communication, although many children do want to know about their illness, this isn't universal. A study of childhood cancer survivors found that some had what's called embraced their cancer and become experts and advocates, whereas others felt with hindsight that their limited understanding had actually helped them cope. Children's communication may be inhibited by their insight into how distressing and upsetting talking about their illness is for their parents, or they may not share their fears so that healthcare professionals view them as brave and courageous. Ineffective communication can also arise when parents don't have an accurate perception of their child's understanding, and this for me is such a key point. An Italian study found that parents tended to underestimate how much younger children understood, and so didn't give them enough information, whereas they overestimated how much older children knew and understood, and so gave them too much or too complex information. If we think now from the parent side of the triad, parental communication is linked to parents' own understanding and emotional response to the diagnosis. Parents who were very shocked and struggling to grasp the information were more likely to tell their child as much as they understood, including that the diagnosis was cancer, whereas parents who thought the diagnosis was incurable and would result in death gave their child as little information as possible. Understandably, parents are concerned that talking to their child will lead to questions that they can't answer. Being asked, "Will I die?" by their child being particularly feared by parents, who may then avoid the whole topic completely. The ongoing stigma about HIV is also important to highlight in terms of inhibiting conversations, and parents describe particularly fearing questions about where the HIV came from, or that their child would disclose their own HIV status or a parent's HIV status to other people. Finally, of course, every parent wants to protect their child from distress, and many parents describe feeling fearful that talking to their child will create uncontainable distress or will have a negative impact on their child's psychological well-being or cause them to lose hope. And then finally, if we think about the third point in that triad for the healthcare professional, their contribution to this triad is also influenced by their own professional and personal beliefs. Healthcare professionals describe barriers to communication in terms of their own perceived skills, or not having enough time for these conversations, or a concern about challenging a family who appear to be coping by not thinking or not talking about the possibility of their child's death. Clinical uncertainty about the diagnosis or prognosis can also affect healthcare professionals' willingness to communicate with families. And of course, these painful situations can also trigger our own memories of loss and grief within our own lives. Interestingly, one study suggests that professionals can seek to manage their feelings about these kind of conversations by creating distance between ourselves and our patients through a sense of busyness or being overly formal, which can impede communication. And of course, not everyone in this communication triad will have the same view of what and how information should be shared. And we can't ignore the power dynamic between children and their parents, with parents being the gatekeepers of information that's then shared with the child. Most importantly, we also need to be alert for situations in which both the child and the parent are trying to protect one another by pretending that they're okay. And this leaves children to face difficult information and difficult situations alone.
So now if we think more about when a parent is diagnosed with a life-threatening condition, again, we know this is very common, and we know that many adults are diagnosed with such a condition with children living still at home. So then you've got this dual challenge where you're coping with your own diagnosis while still trying to be a parent. Again, the stats speak for themselves in how common this is, and again, the differences between low and high income countries, with the effect with the disease not only being more common, but the survival rates again being much lower. Again, the parent paper found very similar outcomes to the child paper in respect to how effective communication has an effect on the psychological behavioural outcomes of the child and of the family. So you can see here that, again, not telling children of the illness led to telling children about parental illness led to lower reported depression and anxiety, so better psychological functioning. And conversely, not telling them increased total problem scores and behavioural problems in the children. Of course, these results do vary, and studies do show differences in when children are told of the parental diagnosis and how much they are told, and that's quite important to a lot of this literature. So what's interesting in the parental papers is that intervention studies are slightly more common, and they have shown that there are clear benefits to communicating with children. So what is a little bit tricky when we look at this data is, again, like I said at the beginning, communication is often not the primary outcome, but is a component of the intervention. But even so, those have shown significant effects on psychological functioning. However, there is one study that we that our team led on, called the Amagugu study, which was with our collaborators in South Africa, led there by Tamsin Rocha. And this was an intervention study which was specifically about communication. And it was there to help the HIV positive mothers disclose to the child their HIV status. And what we found is improvements in engagement with healthcare, in the mother-child relationship, and also the mental health of the mothers and the child. So that was actually to date still the largest randomized controlled trial looking specifically at communication. So I hope from our very brief overview of the outcomes, you can see that there is obviously clear benefits and all the science points to this. So what we wanted to then do is, as part of our review, is to convene an expert group, like I mentioned at the beginning, of clinicians and researchers who have extensive experience of working with children and families affected by life-threatening conditions, both high-income and lower-middle-income countries. So we came together for a 2-day workshop where they looked at the results of our literature reviews and also some previously published recommendations. And we put all this together with their clinical and academic perspectives and produced a framework of principles to help healthcare professionals undertake these difficult diagnostic conversations. So what's really important for me to tell you is that we know with this framework that every principle might not apply to every situation. And of course, healthcare professionals should still use their clinical skills and judgment with each family. And again, we recognise the differences that exist culturally. Although we did have 2 workshops in South Africa and Uganda where we did adapt these guidelines and framework with respect to these 2 populations. And we know that one size does definitely not fit all. So there may be circumstances where you can't go through every step in our framework due to the situation you find yourself in, perhaps a sudden bereavement, or that the parents or child can't take on this information all at once.
So if we think now about the specific challenge for communication during the current pandemic, there of course have been a number of different key changes in the way that healthcare has had to be delivered to minimise the risks of infection. And although there have been some recent changes, the situation remains very dynamic across different healthcare settings and different countries. So I just wanted to highlight some of those particularly relevant when we're thinking about communicating with children. Although children themselves don't appear to be physically affected by COVID in the same way as adults, actually our understanding is that this has a very significant effect on their psychological well-being. So one very significant change, of course, is that patients, either those with or without COVID, have been cared for in hospital without family visits. This means that staff haven't been able to build a relationship with family members as they usually would, and to find out who is important in a patient's life. And this really exacerbates the invisibility of children. So our work very much tries to emphasise that these important relationships might not just be with biological children or grandchildren of the patient, but also extend to, for example, stepchildren or other members of the community to whom the patient was a crucially important figure. So it's really important that we're thinking more broadly about which children need to be told about what's happening and how we might do that. And of course, sensitive news about a patient's deteriorating condition or death has frequently had to be shared by phone. And we also have to think that this is in the context of many adult specialists not seeing communication with children as part of their role anyway. So families are left with the potentially devastating news. And of course, children are very aware of phone calls coming in, particularly those that are taken behind a closed door. So adults have very little time or privacy to prepare what they're going to say, particularly when we're perhaps living in much closer proximity with our family members due to the lockdown arrangements. And of course, family illness and bereavement, they're not new phenomena. And it's something that many children have had to cope with at some point in their lives. But I think what's particularly important to emphasise is that the usual routines and support structures like school or clubs which offer children a refuge of familiarity and are so important in promoting their resilience, have been totally absent, or in the UK at least, are just making a very tentative return. So although these situations in themselves are not completely novel, actually children's mechanism of coping with them is really being significantly affected by the regulations and rules around the pandemic and to stop kind of transmission of the virus.
So therefore, in response to our worries and our own fears, and also based on the reviews and the framework that I just described to you, we were approached first by our local NHS, so our local hospital, in trying to help healthcare professionals who are now having to make these devastating phone calls to relatives. So obviously right at the beginning, no relatives were allowed in the hospital at all. And I know that this is changing throughout the world and even in our own, in the UK, sporadically. So what they asked us to do was using all of, using our framework as a base and then our own expertise, we created a platform of free resources, and these are free. Please share the link widely. We are completely, what we're so passionate about is that this is getting to the front line where people are having to make these conversations. So what we created was a very step-by-step infographic and also an animations to help guide these difficult conversations. So we have done them for healthcare professionals and care home staff. And then, as Louise just described, the families are then left with this news that they've received of a loved one's death, and then they have to then go and have this conversation with any children affected. And so we have also made a step-by-step guide for them and an animation to help them guide this conversation. It was also very important to us now schools have started to go back to some form of normality, that, as Louise described, they're often seen as a sanctuary for children where perhaps they can ask difficult questions that they don't want to ask at home. So we thought that school staff would perhaps, although incredibly experienced with dealing with bereavement and grief and difficult topics, may not, we felt that they may need a little bit of extra support in trying to answer children's difficult questions, specifically about illness and death. So I hope you can see that what's absolutely critical to us is that children are seen and they are cared for in these conversations. So what is different in our resources, and there are a lot of amazing resources out there on how to talk about COVID and the virus and transmission, but what was actually absolutely critical for us is that there was a step within the healthcare professionals guide that specifically asked whoever you were talking to, a relative or a loved one, if the patient had any important relationships with children. And as Louise described, this could do it to extend not just biological children, but important people, if this patient had important relationships with children within the community or the wider family network. So we've been really lucky that these have been cascaded through various organisations, but we're always so open for other people to help us with this dissemination of these guides and animations. And again, they are free to access, download and share. It was very important to us that they were translated into multiple languages, and again, any help with this would be gratefully received. And we also, using our colleagues in lower middle income countries, we actually produced an international version which may be more appropriate in more low resource settings compared to, for instance, our local hospital here in Oxford. So we know that things have changed and that we are definitely moving away from the traditional consultation methods. And this again was highlighted when we were contacted by our local paediatric oncology team, who again felt they just needed a bit more support in how they were going to have conversations over the telephone with their patients about test results, treatment options, and actually, sadly, if there was nothing more that could be done for some of these patients, what the end of life care provisions were. So again, we made more infographics and step-by-step guides for these professionals, and again, the families, when they're given this news, how they will then disclose this information to their children on having these difficult conversations. So although these were specific for paediatric oncology, this is relevant to so many other disciplines. And I know that more hospitals are opening up their clinics for face-to-face consultations, but this COVID is not going to go away. And we fear that there will be changes in the method of consultations forever, perhaps. So the importance of these guides will become even more apparent. So just very quickly looking at the time, I'm just going to show you 1 minute of what this animation looks like, just so you can get a flavour of what we're trying to achieve.
This is a guide for healthcare professionals to take you step by step through the process of telling relatives by telephone about the death of a patient from COVID-19. There are 7 steps and advice if the patient has children in their family. This video is supported by 2 written guides, one for you as a healthcare professional and one for the relative to help them tell any children in the family. First, prepare yourself. Take a few slow, deep breaths to help you focus. Check the patient's information. What's their name? Do you know if they have children or a partner? If you can, relatives have found it helpful to know the name of who was with their loved one towards the end of their life. Check the latest protocol for when a patient has died and what bereavement support is available. You could practice what you're going to say with a colleague. Find a space where you won't be interrupted. Pass your bleep or phone to a colleague, and if possible, use a landline. Step 2, starting the phone call. If the person does not answer the phone, do not leave a voicemail. If they do answer, introduce yourself by name. Clearly explain which team and hospital you're calling from and establish who you're speaking to. Check that they can talk privately. Speak slowly. Counting to 3 in your head can help slow you down, particularly if you're feeling nervous. If the person is very distressed, they may ask straight away if their relative has died, but don't rush into it. Just continue to the next step, the warning shots, which prepare.
So hopefully you can see that this is a very practical guide, and it very much takes you step by step with phrases you can use and responses you can give in reaction to common questions that we know that could come from a relative.
So if you can imagine for a moment that you've just received a telephone call to say that your mother has died from coronavirus. Your 2 children are downstairs, well aware that you've just answered your phone behind closed doors. In the immediacy of your own shock and distress, you now need to walk downstairs and tell your children this life-changing news. So we made these resources with this moment in mind, with the aim of making these seemingly impossible conversations possible. We very much welcome your questions and particularly your feedback on the resources that we've developed. They can all be found on our website, and there's also a link there to an evaluation survey. We'd be absolutely delighted to hear from anyone who might be interested in collaborating or developing this work further with us together. Thank you very much indeed for joining us today.
Thank you so much for that. I learned an awful lot during that 40 minutes. I think you'll agree that everybody here that there's some really interesting research going on in this area. I think it's something that, because we don't like to think about it, we don't want to think that we'll ever have to do it. You know, it's avoided a lot. So it's really valuable, and definitely learn something there, because I think a lot of people probably think it's better to dress things up in a nice way for children, you know, because we don't want to hurt them. Of course, we don't want to hurt them and we don't want to upset them. But that in itself can hurt them, you know. So thank you so much. I just wanted to ask, part of your presentation, you mentioned that I think in a study with children with HIV, that the CD4 levels were lower in children who had been communicated had their illness communicated properly, and were higher in those that didn't. I'm just wondering, like,
the other way around. So it's fine.
Oh, the other way around. Sorry. Do you think it was? Do you think it was to do with how they were looking after themselves because they knew this information, or is it something like a positive thinking? I know we talk about this, but we can't obviously measure how, you know, your thoughts and your how positive you are affects your physical health as well.
I think it just, we give that example because I think it nicely illustrates just how actually it has effect on treatment adherence. And obviously with HIV you have to take your drugs regularly, and if you know why you have to take them regularly, and you understand the importance, and that you know that you'll stay weller and you'll feel better, then you're much more likely to take a drug than if you're just told that, you know, I know with my own children, you try and give them vitamins every day and they kind of do it, and you tell them why, but it's not actually going to have a huge effect on their life. But actually, if you sit down with a child or an adolescent, which is very important, and actually explain what happens, and obviously CD4 counts, the lower your CD4 counts, the iller you are. And then once your CD4 is much lower, then you progress to AIDS. If you explain all that in an age appropriate way, then you can understand why a child is much more likely to adhere to their treatment regimen. So yes, it's very much to do with that understanding, and again empowering the child themselves to advocate for their own healthcare. So actually, you know what, I will take this because I've decided I want to do it, not that someone's telling me to do it. Although that obviously with younger children that's slightly different, although you should still tell very young children about the disease because they understand, they know. We know from our Amagugu study, so we had age appropriate pictures of how you describe what the HIV virus is and why mummy, and how the medicine helps mummy feel better. And we know that very young children understand that, and pictorially and with animations again. So we know, so I think the main point of hopefully for our talk is exactly how you summarize, is that you don't want to upset children, you think you're protecting them, but actually you're doing the absolute opposite. Children understand everything. You should help them understand, and they should know, because it's not fair for them not to know. So yes, but I don't know about the positive thinking perhaps, but that wasn't looked into, but potentially.
Brilliant. Okay, thank you. One of the other things I was wondering about, sometimes, you know, if it is bad news that somebody has passed away, do you think it's a benefit sometimes to have a close friend of the child with them at the time, so that they can go away with them maybe after and digest what they've heard? I don't know if that was part of your research at all. It's just something that occurred to me, that I would imagine that when this information is conveyed, sometimes children want to go off into the room, you know, away from people, and maybe to have somebody there, like a good school friend, or somebody that they can talk to with them.
So I think it's a really interesting point. That's not something that's been kind of particularly looked at in the research. I think what we have kind of put in our framework is can be beneficial for the adult that's doing the telling, potentially to have the emotional or the practical support of a friend or a relative to help them, particularly if parents are concerned that they might break down and get very distressed explaining to the children, so that they have that support there. And I think then, in terms of what the children then want, it's going to be quite individual, and again depend a bit on the age of the child. So some children may then go off and play, and adults can think, actually, I've just told them something, they've gone off to play, does that mean they really understand what's been said? And that may absolutely be just the child's way of coping with that. Other children become very upset and need lots of cuddles and reassurance, and again, that's very, very normal. And again, often older children might want a bit of space and an opportunity to talk to somebody else. What's interesting is the research that when it's the adolescent themselves that's unwell, actually the people that they wanted to talk to, they wanted to talk to their medical team themselves, and then they wanted to talk to another young person that was also going through a similar experience. that actually they often felt quite disconnected from their peer group because they felt that their peers wouldn't understand what it was like. And certainly building on that idea, there's a lot of different support groups within the UK for children who've experienced bereavement, where again their experience is one that's shared with their peer group, rather than perhaps being the only child in their class who's experienced the death of a parent. So again, perhaps it's having the opportunity to talk to another child who has a similar experience seems to be important.
And we did include that in step 4, I think it is, of the family guide, where it does say, you know, these are common, exactly what Louise said, these are the common reactions children might have. With younger children, you may have to have this conversation multiple times. They might not understand all of it, or they might want to revisit it. And again, because of lockdown, there isn't so much opportunity for adolescents or children that are allowed to go out on their own to meet up with their friends, although that is changing, but it changes by the day. So I think in our guidelines, we didn't explicitly say that, just because we felt actually kids haven't really got the opportunity to mix with anyone at the moment, although obviously you can do this online, but that again has to be done with, we always encourage parental support with any online stuff, because they need to go to the correct and well supported and what's the word,
kind of this, I guess, just thinking about internet safety generally.
Yeah, internet, yeah. I didn't mean invigilated, you know what I mean.
Monitored.
Where people have moderated, so people actually moderate the website. So if they are helplines, that they're moderated appropriately, so no one is left, you know, with very severe psychological problems. So again, we always encourage that to be done. We don't mean that a parent should sit next to the child whilst they're doing it, but make sure they are accessing the correct websites.
Okay.
Of which there are lots out there actually that are very good.
I'm just wondering if we know at this point in time, you know, if there is some psychological long-lasting effects, like are these into adulthood, or are they just, you know, for years?
So some of the studies have been in qualitative in nature, talking to adults who experience bereavement as a child, and again adults at that stage talking very powerfully about how that experience has shaped their life, and particularly the way that they were told, or the way that these situations weren't talked about within their family. So there is qualitative evidence to suggest that the effects can be long-lasting. Again, there's been some population studies, but again, it's very difficult in terms of thinking about a control group and so on. But a Swedish study, again, found higher rates of psychiatric distress in young adults who had experienced a bereavement during their childhood. So yes, that there can be evidence that this can be long-lasting. But equally, I think it's also important to reassure people that sadly bereavement is a normal part of life, and that many people you know, experience bereavement and experience a very normal psychological reaction to that, and to grief is again a normal part of response when we lose somebody that we loved or who's important to us, but that people do and can recover from that. So it isn't the bereavement itself which is associated with long-lasting psychological problems. We really can mitigate the impact of that in terms of the way that we then support both adults and children after a bereavement.
Excellent. I think that sums it up nicely. Well, it's a good sign that we haven't got many questions in here from the audience, as one of our attendees has said. Thank you for sharing the research so clearly, because it really was very clear, and I'm really looking forward to looking into the resources you've made available. We'll add these to the website as well as the recording. So I just want to say a massive thank you to both of you, and congratulations on this huge body of work that you're doing. It really, I mean, you've definitely found a void in the research, so and you're filling it. So thank you very, very much, and I hope everybody enjoyed it.
Thank you.
Enjoy the rest of your day.
Thank you very much.
So much.
Thank you.
Bye. Bye everyone. Bye.
Bye bye.